Welcome once again into the Radiopedia Reading Room, a podcast unconcerned with books or poetry, tea leaves or palmistry. This is a radiology podcast. My name is Andrew Dixon, and joining me, he's devitalised and in need of debridement. It's my co-host, Frank Gaylard.
Oh, that's gross. Is the main segment about, let me try and guess, necrotic flesh-eating medical maggots?
It's not a bad idea, but that intro was a little bit harsh and not clear. Let me have another little go here, Gaylard. Maybe it was about death cap mushroom. No, it wasn't about that either. All right, let me have another go. Here we go. And joining me now, it's the ulcerated cloaca himself. It's Frank Gay. Sorry. Couldn't
You're
resist
obviously
doing it
in one
again.
of those moods, aren't you? Oh, are you cranky because of all the conference work? Just a bit busy, Dixon? Not sleeping enough? Not getting your belly
Yes.
rubs?
Busy, but mainly excited, Gaylard, because the conference it's looking amazing. I really can't wait for people to check it out this coming Monday. So amazing lectures and panel discussions, but also there's more interactive cases and workshops than we've ever had before, and it's a real feature of the virtual format, which is fun and exciting and something you can't do at other conferences. So definitely it begins on Monday or Sunday if you're in the Americas because of the way time zones work. It's free for Radiopedia All Access Pass holders and in low and middle income countries. 120 days, Gaylard, of on-demand post-event access. So you've got time to watch it all.
Just enough time.
But you must register before the live event finishes. Okay, so go ahead and sign up now if you haven't already. And Frank and I will both be looking forward to seeing you online. How's that? Was that a nice little plug?
Very good plug. But I really love how the conference has become a focal point of the Radiopedia calendar. Because not only do we get all these amazing lectures, and I have to say, every time I do an online conference somewhere else, like another North American conference or European conference, it only serves to remind me of how good our lectures are, how well prepared, how good the audio is and everything. But anyway, in addition to getting all these lectures, it also means that we add lots of multiple choice questions to the site, and we add lots of cases, and we review and update lots of articles. So it's great. And hopefully we'll see all of our listeners there as well.
All right, so today's main segment, Gaylard, is not about death cap mushrooms, but that's definitely a topic for another time.
Hey, we could have a mushroom segment from now on.
we could. Don't tempt me. So this main segment is all about musculoskeletal infection. So friend of the podcast, Professor Matt Skalski, will be chatting with Dr. Erin Alaia, Associate Professor of Radiology and Orthopedic Surgery at NYU Langone Health, where she's part of the Musculoskeletal Radiology Division. And of particular relevance to today's episode, Gaylard, is that Erin co-authored the 2021 Society of Skeletal Radiology consensus paper titled MRI Nomenclature for Musculoskeletal Infection, which has significantly advanced and standardized MRI terminology in this field, and we'll be hearing all about that.
So I'm a little bit torn about MSK. Because
I see what you've done there, a little pun.
Oh, yes, inadvertent. On strained or sprained, anyway. On the one hand...
It's definitely strained, that pun.
It's definitely strained. On the one hand, you know how much I love to be precise and pedantic about terminology. You know, it's very much in my wheelhouse. It's such an excellent overlap between pet goats and people using incorrect terminology, and it's something to really grind your teeth about. So you'd think that MSK radiology would be just my thing, right? Because there's so many terms and classification systems. But I could never get into it. There's just too many of these type 1A, subsection B, flowchart, rubbish things in MSK. I don't like it. It's boring. So much of it is finding new, difficult ways of classifying and naming bits of collagen that are torn, and I can't do it. How do you find the overlap between neuro and MSK? Because you do both, right?
Well, so my preference between the two very much depends on the context of where I'm working. When I was in private, I found MSK way more interesting. You know, young patients who've injured themselves on the weekend, torn meniscus, torn ligament, you know, nice cases that have an answer, but they're all kind of unique. Every tear is a little bit different and the different patterns of things. Whereas in private, the neuroradiology component of it was all just, you know, headache And
Yeah.
almost all of the CTs and MRIs were completely normal and boring to report, and you're not using your knowledge as a neuroradiologist. But in public hospital work, it kind of flips around. So MSK becomes just follow up of fractures. This is in Australia, obviously. Follow up of fractures, knee replacements, degenerative spines, and less of those acute kind of nice, isolated kind of knee injuries and shoulder injuries and stuff like that. But then in neuroradiology in public hospitals, that's where all the pathology filters through to, right? The interesting tumors, the weird and wonderful, undifferentiated brain diseases. So for me, it's all about the discovery of new things. So, having to crack the case. That's what I enjoy about radiology. So it's more of that than the subspecialty itself.
Yeah, I was actually talking about different subspecialty areas within radiology with a trainee. I'm not sure if it was Jack or Bridget or maybe one of the Chua triplets. Anyway, that's a long story. Don't. Anyway, hello, whoever it was that I was speaking to about this to.
Yep.
But they asked me if I thought different personality types are attracted to different radiology subspecialties in the same way that different personality types are attracted to different medical specialties. The jock surgeon idea or the nerdy respiratory physician. There must be something, right? Because when you think about if you're a breast radiologist, you need to be happy to spend your career looking at one organ that gets two diseases. And that takes a very different kind of mindset to an MSK radiologist or an interventional radiologist or a neuroradiologist or a chest radiologist, where basically you've got no idea what's going on. You have to read the history and biopsy it. I don't know. Do you have a feeling of whether there's specific personalities that map to subspecialties?
It's interesting you mentioned this, Gayla, because, and I think you know this, I've recently been writing a short creative narrative to accompany the daily subspecialty themes for the virtual conference. It's a sci-fi kind of story that uses the planet space theme that we've got in the conference for the different days and draws analogies to different radiology subspecialties. Anyway, I won't say too much about it as I don't want to spoil it for people. And I know I haven't actually answered your question here, Gaylard, but I'm excited because I just got a professional narrator to record this narrative for each day so people can have a listen, and it sounds awesome.
Yeah, it does. I've heard snippets and it's great. And I'm glad, Dixon, that yet again I've served to inspire you. I know this is your tiny attempt to match my unpublished novel writing exploits, but as usual, you actually got it finished and shipped and, it's out there, whereas mine will never see the light of day.
Yes, shipped, but a captive audience, really. Still an audience, but a
It is
captive
still an
one
audience.
at the conference. And when I say I wrote it, it was very much an experimental collaboration between me and ChatGPT.
Oh,
So, yeah.
oh, that'll be interesting.
Anyway, we better get back on topic here, Gaylard. How about a quick game of Spot the Fake MSK Infection Edition?
All right, why not? Another opportunity for embarrassed Gaylard in front of a captive audience. I'm not sure how captive this audience is. They can leave. They probably
That's
have.
true.
There's probably no one left by now.
No,
The
they
breast
love this.
radiologists have been alienated. The MSK
that's true.
radiologists, respiratory physicians, they're all gone.
We've just got Death Cap fans here now. That's it. All right. Spot the fake. 4 statements. 3 are true. 1 is fake. And your job, Frank, is to spot the fake.
Okay.
Now, all of these are taken from the aforementioned Society of Skeletal Radiology consensus paper 2021 on MRI nomenclature for musculoskeletal infection. I'm assuming you haven't read it, Gaylard.
It'll shock you to know that I have not read this.
Excellent. Statement number 1. Is it true that osteomyelitis can be confidently diagnosed on MRI without contrast if marrow signal is hyperintense on fluid-sensitive sequences adjacent to an ulcer, abscess, or sinus tract? You want to take these as we go?
Yeah, I think so. I mean, that sounds pretty true. You've got an infection and the bone next to it looks abnormal. Sure. Yeah. Okay.
Even without contrast. Okay. Statement
Yeah.
number 2. Is it true that...
Contrast is highly overrated, at least in the brain. We give contrast all the time. And honestly, half the time, it's like, why are we doing this? We know there's a meningioma there, and all you need to know is whether it's bigger or not. And yet we insist on poisoning our patients. I'm cranky today. I'm punchy and cranky.
It's very good. Is it true that, statement number 2, is it true that the term osteitis is preferred over osteomyelitis when marrow signal changes are present, but without definitive cortical destruction.
Hmm. I mean, osteitis means just inflammation of bone, right? So if you have early infection, you would have inflammation of bone. But it feels like, I don't know, I wouldn't use the term osteitis myself, because you don't want to tell someone that it isn't infected. On MR, you can't see cortical destruction or bone destruction that well anyway. So if it's next to an infection, I wouldn't know. No, I'd say like early osteomyelitis or something. I say that all the time in the spine, for example.
So you're
So
leaning towards this one being fake, but maybe I'll read out the other options first
yeah,
and then you.
yeah. So far, this one sounds like rubbish.
Statement 3. Is it true that the penumbra sign has a specificity of around 96% and refers to a relatively T1 hyperintense rim at the periphery of an abscess cavity on pre-contrast images representing vascularized granulation tissue?
I mean, there's so many spots in here that could be made to be fake. Like it could be not 96%, it might be 92%. I don't even know what the penumbra sign is in
That's the other
MSK.
thing.
It's clearly not the penumbra sign that I know of.
I just thought, hey, that sounds like a brain thing Frank might think of.
Yeah, I'm going to
Penumbra.
ignore. I don't know.
You don't know. Okay.
Yeah.
Statement 4. Is it true that devitalized tissue may appear deceptively normal on fluid sensitive sequences, but post contrast imaging reveals it as sharply demarcated, non enhancing soft tissue, often in diabetic foot infections?
Yeah, that sounds true. I mean, that is a role of contrast, right? That is a thing that you can't get without contrast, is working out whether blood that carries contrast can get into tissue.
So now
So
you're like in
yeah,
love with contrast again. Come on. It's a love hate relationship.
it is love hate. So look, I don't know about that penumbra thing, but I don't have any reason to think that it's not true. Whereas I think the osteitis one sounds like bollocks. So I'm going to stick with that one.
All right. Well, we're going to find out after listening to this main
Mm,
segment,
okay.
Gaylard, because we're going to get the answers in there. So this is Dr. Matskowski chatting with Dr. Erin Alaia about musculoskeletal infection. This chat took place directly after a lecture by Erin played at our 2024 virtual conference. So you will hear them both referring to the lecture at times, but I don't think it impacts the ability for you to understand the discussion. So listen in, and then Frank and I will be back for another chat in the outro. I'm now joined by Dr. Erin Alaia so we can have a chat about her lecture. Welcome, Erin, and thank you for your awesome talk on musculoskeletal infection.
Thank you so much, Matt. Happy to be here.
You talked about a lot of important things, and one of the things I kind of like to think about is, there's the diagnostic side of things, which is, of course, why a lot of people watch this, but sometimes the more practical thing people take away is reporting do's and don'ts. And so I thought I liked how you emphasized that you shouldn't report that things are drainable and also not call things reactive osteitis. Can you just kind of reiterate those points for the people watching?
Yes, absolutely. So, a lot of the points in this talk really came out of the Society of Skeletal Radiology white paper on nomenclature for musculoskeletal infection. And one of the driving features that led to this white paper initially was this problem with discordant marrow signal on MRI. So, what is discordant
Mm-hmm.
marrow signal? It's when you have high signal in the fluid sensitive fat suppressed images, but you don't have that matching confluent low T1 signal that we like to see to call definite osteomyelitis. So the problem is that a lot of radiologists, when they saw these findings, were using the term reactive osteitis. And, that doesn't really translate to anything clinically meaningful. It doesn't translate to actionable findings that our clinicians can use, whether or not to treat with antibiotics and so forth. So that's why we really sort of addressed this problem of this discordant marrow signal. And we recommended that when you see discordant marrow signal deep to an ulcer or soft tissue infection, that this should be more emphasized as likely early osteomyelitis. And we really throw out that term reactive osteitis. And then the
Mm-hmm.
other, reporting don't that I discuss in my lecture was the drainability of an abscess. A lot of times people put in their reports that this abscess is amenable to interventional drainage. This is something to just really be careful about including in your report. First of all, if you say that something's drainable, it kind of puts the impetus on the interventional radiologist to do the procedure when it may not be clinically warranted. And if you look at the
Hmm.
Society of Interventional Radiology guidelines for abscess drainability, it's not based on size, location, abscess depth. So it's difficult for us as radiologists to actually assign that term just based on the imaging features alone. And it's another term that really should be avoided.
Yeah. So it's more of a clinical decision, really. And so you should leave it up to clinicians to decide that.
Yes.
Yeah. And then, kind of if you say something's drainable and then it doesn't get drained, that's also a problem then if, or potentially can become a problem that was reported as drainable and it wasn't drained or something like that. So yeah, I think it's important to kind of let the people responsible for the outcome of the decision make the decision.
Yes. Agreed.
You also talked about Charcot joints, trying to distinguish that between infection in the foot because that can be difficult for a lot of people, and it's a common problem that we have to deal with. And so I really liked how you kind of emphasized looking at the individual features of reticular versus confluent T1 marrow signal change, and then looking for that superficial infection and that type of stuff. I don't know if you want to kind of just reemphasize some of those features that you're really looking for when you're trying to make that call.
Yeah. So, you know, diagnosing osteomyelitis in patients with Charcot arthropathy is always a challenge. And that's because patients with Charcot arthropathy have several signal and structural features that are seen in patients with osteomyelitis. So they'll have bony destruction, they'll have marrow signal changes on the fluid sensitive images. But it's important that these findings are always periarticular, they surround a joint. So this is unlike what we see in osteomyelitis in the foot. It's almost always due to contiguous spread. And you're going to see, bone destruction, marrow signal changes in a Charcot patient with osteomyelitis adjacent to the soft tissue infection or ulcer. And the other point that you emphasize is that the importance of the T1 weighted images, right? So although patients with Charcot arthropathy will show marrow signal changes on the fluid sensitive images, again, they're almost always going to be periarticular in distribution. If you go back to the T1 weighted images, you're not necessarily going to see that confluent low T1 signal. That's what we're really looking for to be more confident in a diagnosis of osteomyelitis. But the bottom line, and I think the most important really, is you're looking for, the presence of an adjacent ulcer or other soft tissue infection to really allow you to come down hard on this diagnosis of osteomyelitis in a patient with Charcot foot.
Yeah, I like that. I think that's something that'll help a lot of people kind of in boosting their confidence with that because I know that's a area that can be very tricky for a lot of people.
I was also going to add that patients with Charcot arthropathy will frequently have fluid collections in the soft tissues, but they're not necessarily going to be an abscess. It could be a bland fluid collection, for example, an adventitial bursa in a patient with a rocker bottom foot. And for that,
Hmm.
another useful clue is if you look at the subcutaneous fat around the fluid collection, it's going to be very dirty in a patient if it's an abscess. It's going to show regional cellulitis, whereas a bland fluid collection, an adventitial bursa, will show a relatively clean, intact appearance of the surrounding subcutaneous fat.
Yeah, thank you. That's really good to emphasize. And then kind of along that same side of things, you also talked about distinguishing between bland edema and infection, and kind of some of those similar things. Talking about but also kind of adding in the enhancement, kind of being more local versus absent in bland edema. The extent of involvement, whether it's bilateral, would be a clinical distinguishing feature, typically. And then looking for kind of localized things like skin thickening, septal thickening, which you'll see with infection, but not with bland edema. And so I really like that you kind of gave us this little package of things to look for to distinguish between those two things.
Yeah, so basically, cellulitis is going to be more of a focal process. It's a superficial soft tissue infection that's going to occur deep to a breach in the skin, so an ulcer, sinus tract. And to be confident in your diagnosis of cellulitis, you really need intravenous contrast. But again, I discussed several of those clinical features that are going to help you differentiate bland edema from cellulitis. So cellulitis is again going to be more unilateral, more focal. Patients will have laboratory findings indicative of infection and elevated white count, elevated inflammatory markers, whereas bland edema is going to be more bilateral, seen in patients with cardiac or vascular insufficiency. And again, cellulitis is a superficial soft tissue infection. It's really going to exist above the superficial fascia. And this is in contrast to necrotizing fasciitis, which I also discussed in my lecture, which is a more of a deep soft tissue infection. Necrotizing fasciitis will involve the deep fascia that envelops the musculature. So, it's important to differentiate that from cellulitis.
Yeah, that's excellent. Yeah, and some people who follow me on social media may have saw I did some fascial diagrams to help, talking about deep fascial infections and these things as well. Um, all right. So, and another thing you mentioned, when people have chronic infections, that chronic oxidative stress, just like any kind of chronic irritant, can malignantly degenerate as well. And so, when you see more mass-like patterns of enhancement, these things you have to be considering, a malignant degeneration of the infectious site.
Yeah, absolutely. I mean, this is something that is very rare. In fact, at our institution, when I look through cases, I'm aware of only one case of malignant degeneration in a patient with chronic osteomyelitis. You have development of squamous cell carcinoma. And again, as you noted, you want to look for sort of nodular mass-like enhancement along the sinus tract, the area of the chronic wound, as an indicator and something to really certainly keep in the back of your mind when you're evaluating these cases.
Yeah, and I looked this up again because I had in the back of my head from residency, I had learned that malignant degeneration of a sinus tract was called a marginal ulcer. And I Googled it again just to refresh my memory, and it said that they actually didn't provide infection as one of the causes of a marginal ulcer. It gave things like burns and poorly healing wounds and scars, but it didn't specifically mention infection. So for the people who like to, you know, do trivia, they can maybe throw marginal ulcer into their head as any type of a malignant degeneration from a chronic wound, including infection in this case. The next topic that I thought was important that you mentioned was um, using contrast to help delineate areas of devitalized tissue and specifically reporting that so that it can be a target for debridement. Can you kind of just reiterate that?
Yeah, absolutely. I mean, there's always a lot of controversy in the world of MSK radiology as to whether or not we should administer intravenous contrast to patients with a diabetic foot infection. The IV contrast images take, a lot more time, add more time in the magnet, and we're always wondering how clinically meaningful the contrast really is. So one of the best usages and need, sort of advocating for the need of contrast in these patients is really the identification of devitalized bone or soft tissue, and this is going to show up on the contrast images as sort of a geographic area of non-enhancement of bone or soft tissue. It's not going to be obvious on the T1 or the fluid sensitive images. You really need contrast in order to see this. And as you said, um, you know, patients with soft tissue or bone devitalization, can be addressed either with debridement, resection, or revascularization. And this is something that, when you give contrast, it's also going to be useful to do the subtraction images. It's just going to even make that area of devitalization really stand out and be beautifully shown. And it's also important to recognize that patients that have bone and soft tissue devitalization, that lack of the vascular supply, you may not get the expected confluent T1 signal changes. In order to see that low T1 signal, you really need an intact vascular supply. So I have cases of dry gangrene, so avascularity of the forefoot with exposed digits, and you're not seeing that low T1 signal. But don't be fooled into saying, no evidence of infection. Again, because of that devitalization, you're not going to see the expected marrow signal changes.
Right, and that kind of fits in with what you talked about previously with the talking about reactive osteitis, and you need an intact vascular supply and these types of things. So I think that's applies here as well. So another thing that I thought was really interesting that you mentioned, I think just kind of flies under the radar and has for a long time, but increasing awareness is Lyme's arthritis, and when you have an unexplained effusion, being suspicious for Lyme's disease and sending that aspiration out for serology for Lyme serology.
Yeah, that's a really good point. So, I live in New York City, so the surrounding areas, we have a lot of Lyme infection. So it's something that we certainly encounter clinically. And I'm thinking about Lyme arthritis when I have a large joint effusion, but really nothing to explain it. So the cartilage is intact. There's no meniscal tear. There's no ligament injury. That's when I start thinking about Lyme arthritis. In these patients, you're also going to be seeing enlarged popliteal lymph nodes. It's another distinguishing feature. It's important that you raise the possibility of Lyme arthritis because it's something that specifically the orthopedic surgeons are not necessarily going to be thinking about. So they're going to do an in-office joint aspiration. You just want to make sure that they send off for that Lyme serology. And, I have, in the past known of cases where it was only because the radiologist specifically mentioned Lyme that the orthopedic surgeon sent off that serology and it was actually positive. Now, certainly if the patient is seen by a rheumatologist, they're probably going to be thinking about Lyme arthritis, but just something to
Mhm.
always keep in the back of your mind.
Yeah, I think it's important that everyone kind of be aware of it, and so someone will bring it up, and if that's you, then you might be the one person who thinks of that, um, and because I think it's easy to get in the habit of just dictating the findings and just saying joint effusion with no underlying cause, just kind of leaving it at that, but um, you know, being a good clinician as being a clinical radiologist, often requires suggesting things that other people might be missing, and uh, yeah, so I think that's I really like that you added that in there. Another thing that just kind of like for pattern recognition, I like that you mentioned, when you see SI joint arthritis, make thinking that's often seen in IV drug users, and keeping that in your differential. And I was taught in residency that IV drug users get infections in S joints, so that's how I always remember it: SI joints, sternoclavicular, and spine. So those are kind of the places that I think about for infection in IV drug users.
Yeah, no, I never heard that, but that is useful. Yeah, so when you see unilateral sacroiliitis, particularly when you have a big joint effusion, lots of pericapsular and surrounding soft tissue edema, you really want to think about septic sacroiliitis, and in particular, as you said, in a patient with a history of IV drug usage.
Yeah, and that might not be known too, depending on whether or not they disclose that. So yeah, we got to be really
Absolutely.
suspicious of those unilateral sacroiliitis. And really, and I think that brings up the point that everyone should have tattooed on their forehead is that any monoarthritis is infection until proven otherwise. I don't know that that can be said too many times, because I've seen that mistaken. And the same thing with the Lymes. If you have an unexplained joint effusion, it's a monoarthritis until proven. That's infection until proven otherwise. And so if it's not coming back as suspicious for infection, then send it for Lyme serology. So it kind of all ties together that way, I feel like.
Yeah, no, absolutely. A destructive monoarthropathy, you always want to have infection, as you said, in the back of your mind. Um, these are the cases, though, where it is really, first of all, if this is a septic joint, the clinician needs to be aware. You need to pick up the phone and discuss it with the clinician, but you also need to have that discussion with the clinician because I have seen cases of really what looked like a septic arthritis based on imaging. So we're saying a large joint effusion, also pointing you toward a septic. rather than bland or other inflammatory infection is going to be the edema of the surrounding soft tissue. So if you have a large joint effusion, destructive monoarthropathy, and you see lots of surrounding soft tissue edema, that's really going to point you more toward infection, but it's not necessarily going to be infection. I have seen cases of a rip-roaring psoriatic arthritis that was very active, appearing pretty much identical to a septic joint. So, certainly, septic joint always needs to be on the differential. The clinician needs to be aware, but keep in mind that a very active inflammatory arthritis can have a lot of overlap in terms of the imaging appearance.
For sure. Yeah, I think that's it. Yeah. I mean, we always want to make sure we rule out infection first. I really don't like the term rule out, but in this case, infection, it's always prudent. But certainly other inflammatory arthropathies can mimic that. I had another thought and now it's escaping me what I wanted to say about it. Oh yeah, I remember what it was. So another thing that I would, just speaking of SI joint, infection is that oftentimes that will masquerade as back pain. And so, when you're reading your lumbar studies, you always want to make sure you're scrutinizing those last couple slices. And, because I've seen, or I found, a septic SI joint on a lumbar MR, when it was just the last slice or two, which picked it up. So something else to kind of keep in mind, just to make sure you're paying attention to those SI joints, even on other studies.
Yeah, I mean, I'm glad you said that. So in the sagittal stir images, it's very important that you look at every image, including especially the far lateral images, and whether it's sacral, septic sacroiliitis or inflammatory sacroiliitis, or even similar findings I've seen in postpartum patients, just related to stress change across the sacroiliac joints. But yeah, there's a lot of value, and you'll pick up pathology on lumbar spine MRIs when you look at the far lateral stir images. So something really to be mindful of.
Yeah. So before we sign off here, are there any other kind of reporting tips you have? I know we talked about the reporting no-nos for drainage, drainability of abscesses and reactive, not calling things reactive osteitis, because I think if I remember, you said 60% of those will turn out to be infected. So that's more than half. Do you have any other reporting tips you want to add, or?
Just one last feature that I really want to emphasize because I think it's so useful is the presence of this feature known as the penumbra sign. And it's something, I talked about it in my lecture, something to keep in mind when you're evaluating for bone or soft tissue abscess. So, as we discussed, a lot of times we have these infection cases and we don't have contrast on board. The penumbra sign can be really useful in making a diagnosis of abscess. So the penumbra sign is when you see a rim of relative high T1 signal along the periphery of an abscess cavity. And that feature is very specific for abscess. And when you see it, it's really going to improve your diagnostic confidence.
Awesome. Yeah. Thank you for adding that. That's great tips. And, we got a lot out of your lecture. So thank you again for joining me for this chat. I had a lot of fun talking to you, and I hope everyone took something away from it.
Yeah. Same here, Matt. Thank you so much.
Yeah. All right. Bye-bye.
Thank you to Matt Skalski and Erin Alaia there for recording that discussion. Frank, you were right on with your spot the fake interpretation today. Nice job.
I wasn't I? Even a blind squirrel occasionally finds a nut, Dixon. The term reactive osteitis in the context of possible infection is misleading, and it does too strongly suggest that there's no infection. And I think that's the really important point with that particular term. And I think there's something here that I wanted to bring up, which is that I think it's great that these white papers and consensus statements are reached within radiology so that we as a profession standardize our terminology. But it's not as useful unless clinicians who read our reports share the same terminology. And so I think we need to be looking towards more cross-disciplinary terminological alignment so that when a radiologist says X, the orthopedic surgeon has the same understanding of that term. And I guess that gets to the heart of an issue that I know we've discussed before, but it's who is the report for? Is it for the radiologist who's reading the next report? Is it for the specialist referrer? Is it for the primary care physician or general practitioner? Is it these days for the patient? So it's important we use words that, even if they're read by someone outside the inner group who might have specific meanings to those words, that they still make sense. The problem, I guess, is that results in really horribly clunky, describey sort of terms. An example in the spine is high signal intensity zone in the annulus, which, is preferred to using annular tear because often it's not traumatic. And it's preferred to using annular fissure because often macroscopically the surgeons don't see a fissure. Or in the brain, in NF1 patients, you have the focal area of signal intensity, the FASI. And I wonder what GPs think or patients think when they use these terms. They must think there's something wrong with us.
As long as the acronym sounds cool, that's all that matters.
Yeah, I guess they read our reports and it sounds as ridiculous as contractual language in agreements or contract law, don't you think?
But mate, they don't be reading the body of the report, which is where these terms are going to be used. They just skim the conclusion.
That's true.
Now, is there anything else from this panel discussion that caught your attention, Gaylord?
There was one thing, which is the idea of not to indicate in your report whether you think a collection is able to be drained percutaneously. I'm not sure I agree with that. My humble non-MSK opinion. But, in the setting of spinal epidural collections, I always indicate whether I consider a paraspinal or a collection to be drainable. And I think that's an important part of a report personally. What do you think as more of an MSK person?
Look, I understand what Erin and the nomenclature paper are saying, but I'm not sure that it works 100% in the real world, because so many of the requests or queries that I get at meetings, this is the exact question. Is it drainable?
Yeah.
Right? That's specifically what they want to know. So obviously they want us to make some kind of assessment on that. So therefore, preempting that and including it in your report sounds like a reasonable idea. Also, I think the idea of draining for therapeutic effect is different to, is it possible to sample some fluid in order to isolate a bug? They're really two different things. So, for example, in the MRI spine report, if you've got a paravertebral abscess, even if it's small and doesn't really require therapeutic drainage, if they haven't got a bug, then telling them that, I reckon I could get a needle into that and aspirate some fluid may be very, very handy information for the infectious diseases physician. So, yeah, I agree with your assessment on that.
And it also shows, I think, using that terminology, a willingness to do it. Not that I think surgeons or physicians are ever like, oh, I don't want to ask in case I offend them. But to say, I say it for nerve root injections as well. This is amenable to percutaneous nerve root injection.
It's also whether it's absolutely possible. Like there are some where you're like, no, that's not possible. I cannot get in front of the sacrum in that position, right? I can't.
You just have to push harder, Dixon.
That's true. I can get there, but at what cost?
One more thing I wanted to bring up. This is a bit of a community announcement, I guess, because Matt and Erin talked about Lyme disease. And I just wanted to remind people that Lyme disease is not present everywhere in the world. So don't just go calling Lyme disease. For example, it doesn't exist in Australia. We have lots of horrible, dangerous, poisonous, killing animals everywhere. Literally stepping out of your house in Australia anywhere is taking your life into your own hands. There are drop bears, there are snakes.
Oh, yeah.
There are.
Don't remind me of drop bears.
I just had to kill a huntsman, and for those of you who are blessed with not knowing what a huntsman is, it's a big black spider, and this one crawled from under the PlayStation towards me while I was playing Call of Duty with my son, and I crushed it with my mug.
Yeah.
And it was big enough that its legs were visible on the outside of the mug's rim.
Yeah. Bigger than the mug, yeah. They can't actually kill you other than via a heart attack.
Yeah, that's right. But they're quite aggressive. Like they'll come at you they'll pull up its little... I don't like spiders. Anyway, Australia has no shortage of horrible diseases and creatures. But our ticks do not carry Borrelia, what is it,
No.
Bugfori, whatever.
Spirochetes.
Whatever causes Lyme disease, our ticks don't. They carry all sorts of other stuff. They have like scrub fever and Q fever and Queensland hemorrhagic eyeball fever or whatever it is. But we don't have Lyme. But just like everything else in the climate denial and 5G causing brain tumors and everything else, within Australia, there is a vocal small group that believes that Lyme disease does exist and that it's some sort of conspiracy by the government and the medical establishment to pretend that it doesn't exist. And there are some doctors, of course, who fill the niche and will treat Lyme disease. Now, we get the occasional case of people that have contracted Lyme disease from overseas, but there's no endemic Lyme disease.
Yeah. And then we deport them back.
Yeah, well, we don't want Lyme. We've got enough. But I mean, in neuro, we come across it with MS because cerebral Lyme can mimic MS, kind of like small white matter lesions, I think. I mean, I've never seen a case. But do I have time for a micro rant, Dixon?
Go ahead.
Recently, I came across a paper about Lyme disease and MS because I was looking it up. And it was talking about how they thought that actually Lyme disease was the cause of MS because if you look at the geographic distribution of Lyme disease in Europe and North America, it both goes up the further away from the equator you go. Mm-hmm. And apparently there's a seasonal component to it as well. They didn't mention at any point in the article, what about the thousands of Australians with MS and we don't have Lyme here? But since we're only hiding the fact that we don't have Lyme, I mean, maybe that's it. And then I looked at the journal and
prestigious.
Do you want to guess which journal, a publication of the prestigious publisher Science Direct, that this was published in? Have a crack.
Something great.
It's the journal. I kid you not. We'll put the link in the show notes. Actually, maybe we shouldn't because we shouldn't be promoting this. Anyway, it's the the Journal of Medical Hypothesis. This is, so you don't have to actually do any research.
Yeah.
You just say, oh, look, I reckon that eating pineapples reduces dementia. I know that we should expect nothing less from medical publishing industry, which we all know is driven purely by a desire to seek truth and enable human flourishing.
That's right.
And best of all, this journal is open access.
Free to publish.
Well, that's just the tiny detail. To publish in the Journal of Medical Hypothesis, they will charge you
$500.
$3,450 US dollars, excluding taxes. So if you have the spare cash, and let's put this into perspective, okay? So that much money, $3,450 US dollars, will procure and distribute about, 500 insect-treated bed nets to malaria, endemic areas of malaria, saving, children's lives. But if you have the spare cash and you want to do something, then you can write a paper that merely has a hypothesis. Much easier than actually doing any research because you don't actually have to do any of it. And Science Direct will gladly take your money and publish it. And I don't understand how this is different to just a blog post.
Yeah, no, it's the same. It's basically
because what do the peer reviewers do?
To add a bit of legitimacy to your conspiracy theory.
That's right. They get a DOI. They get a line on their CV. Oh, I think I lost enamel on my teeth as I was grinding away.
But do you feel better having got that rant out of the way?
I mean, marginally. I'm still pretty annoyed. Look, okay. You tell me some glorious MSK-related thoughts, and I'll take some deep breaths.
Right. Well, I did write down a couple while I was listening along. So I think the reminder that infection is all about contiguous spread is useful to remember. Obviously, bugs can come in via the blood in kids in the metaphyses and IV drug users going to the discs and facet, the S joints, as Skalski put it. But when we're talking about the foot and ankle, it is all about contiguous spread. So if there is an ulcer or an abscess in the soft tissues and the marrow signal next to it is wrong, then you've got yourself at least likely osteomyelitis. Whereas no ulcer or abscess, but destroyed midfoot, periarticular marrow signal abnormality, that is almost certainly bland edema related to biomechanical stress in someone with a bit of a neuropathic foot. The point also about devascularized tissue in the diabetic foot, I really liked. Absolutely, you need contrast, as you said, in the spot to fake Gaillard. It can look so normal on the T1 and the fluid sensitive sequences, but you give contrast and it's just striking geographic non-enhancement. So don't be tricked by that one.
Yeah.
And if there's no blood supply, then you don't get edema, obviously, and that's what we look for on MRI most of the time. So that's why it's so tricky. It's a little bit analogous to that other classic MSK sign, the Hawkins sign in AVN of talar dome after a talar neck fracture, Gaillard. In that case, if the blood supply is good, then you get osteopenia of the talar dome, which is a good sign. But if the blood supply is disrupted, then you don't get osteopenia because that's an active process. It needs blood in order for the bone to be resorbed and for you to get the osteopenia. So the absence of osteopenia is actually a warning sign on follow-up X-rays.
That's the same as the scaphoid fractures, right? The proximal pole is sclerotic, but it's not. It's just not osteopenic like the rest of the wrist from being immobilized.
Yeah, although you sometimes do get a bit of sclerosis due to once you get collapse and things like that. But
later on,
that's down the line. Yeah.
Did you see how I just put a bit of MSK knowledge on you there? That's like 20 years old.
The way you dropped it.
I know.
Amazing. And then the final point I wrote here is, and I've seen this several times, very subtle edema just anterior to a sacroiliac joint on the bottom of a lumbar spine MRI for back pain. And it ends up being septic sacroiliitis. It gets dramatically worse on the subsequent imaging, but very early, they can be very symptomatic, sore back, and it's a very, very subtle edema that you're looking for on that first scan. So don't forget to, take a good look at those bottom images or the far lateral images and keep that in mind as a differential for low back pain.
Well, the sacroiliac joints, particularly because the posterior joint, which is the part that we see most readily just on axial lumbar spine imaging, is really fibrous and doesn't have much of a synovial space, whereas it's the anterior joint that has more. So that's where often infection starts up.
Yeah, exactly. Particularly superiorly. Superiorly, it's very much a fibrous kind of joint at the back, whereas the more anterior and inferior they go, the more of a synovial joint it becomes.
That point about needing blood supply to develop edema, though, I think is really important. And we see that in the brain in so-called dry infarcts. So when you have a large vessel occlusion, particularly proximal, like T-junction carotid, and it doesn't get revascularized and there's no good collateral, then although you'll have florid persistent DWI changes, you won't get the florid T2 change or the swelling that you get in a patient that is revascularized, because the DWI change is water going from the extracellular space intracellular, whereas edema is additional water being recruited from capillaries, which are receiving fresh blood from collateral. So if that doesn't happen, you don't get edema.
And I'm very tempted to also talk about Avastin and some of the counterintuitive stuff that does as well along here. But I think it might be time for us to wrap this episode up. Gaillard, how can people get in contact with us?
Well, you can email us at podcast@radiopedia.org with any ideas or feedback or, unfounded hypotheses that you might have. We'll publish those as well.
Plus a massive check.
Yeah. But we'll go 50% discount. We'll charge you $1,800 for your hypothesis. Yeah.
And that discount applies ongoing. So if you want to submit another one.
Yeah, as many hypotheses as you've got. You can have a whole issue if you like. And you can, of course, join the Radiopedia community chat by visiting radiopedia.org/community, but no unfounded hypotheses there, please.
You can send us an email just like this one that we received about our recent cut and polish radiology report episode, Gaillard. So I'll read it here. It says, "Hi, Andrew. Hi, Frank." Correct order, so 10 points to the writer here. Absolutely brilliant podcast on the topic. Thank you very much. You mentioned that nowadays there is not only one addressee, but many. I, as a hospital radiologist, personally do read a lot of reports from out-clinic radiologists and my in-house colleagues. So radiologists are frequently addressees of radiology reports too. And then I love specific radiology content such as series/image numbers, like where the hell is she or he seeing a PIRADS 4 lesion? So we frequently add this kind of information in our reports, in the report section, knowing that this is of little use to our referring clinicians. It's mainly for the radiologists. Anyway, thanks for your excellent work for Radiopedia and all of us radiologists. Kind regards and greetings from Germany. And I'm going to read it as Jan because I imagine it's not Jan in Germany, but it would be Jan if they were in Australia. Actually, I'm surprised that, putting an arrow on it or mentioning a slice number didn't come up in that panel discussion in that episode, because it's 100% useful, right? You never get annoyed when you see a slice number reference in a report or an arrow.
I can get annoyed by pretty much everything. So there's one of my colleagues, actually there's two colleagues that their arrows annoy me. One of them because they have tiny arrows.
Oh, tiny.
They're the smallest arrows, so much that you can't find the arrow. And then someone else has these enormous arrows. And the way our PACS does arrows is that the arrowhead is proportional to the length of the stem.
Ah.
And so the bigger the stem, you end up with these arrows that are like the size of the thalamus, and they'll put 3 or 4 of them. It's like, there's a happy medium, people. Just a normal-sized arrow.
I have done, just as a joke before, an abnormality where I put like these spoke wheel arrows all the way around it. Probably like 50 arrows around this thing. I wiped them afterwards, but I took a little screenshot before I wiped them. Nice little joke.
But the series and image number, I don't use them very often, but only because I'm lazy. But recently, one of my colleagues, and I won't name names, but anyone from my department will immediately know who I'm talking about, decided to write to the whole department off their own bat to say, we shouldn't be using image numbers and series numbers in reports. And pretty much everyone kind of like, what? Like, no, this is good. And because I am a petty individual, that actually has spurred me to use series numbers and image numbers far more often.
Nice. Passive aggression. I like it.
Yes.
So this sounds like most people in my department, this kind of behavior. Anyway, thank you to Jan for sending in that email. I'll move on to reading this next bit, Gaylard. And if you want to help support Radiopedia, then you can become a paid supporter via the website or purchase an all-access pass to our online courses and conference. In doing so, you'll be helping us to give free course and conference access to people in 125 low and middle-income countries. And what else can people do to help us out, Frank?
And you can also, of course, help us out by leaving a 5-star review in the podcast app of your choosing.
100%. It'll be great to see some reviews coming through. We'll see you all at the conference. It starts on Monday/Sunday, depending on where you are. Gaylard, we'll both be watching it together this year from a remote destination. Exciting one. Yeah. So I'm looking forward to it very much. And we'll catch you all again sometime soon in the reading room.
Stay rad, everyone. Stay rad and see you soon.
See you soon. Don't eat death caps. Bye.